Hello everyone, welcome back to the channel. Today let's talk about Wellens Syndrome, a subtle but life-threatening ECG pattern that every student must know. It's not just an academic topic, recognizing it in time can literally save a life. Wellens Syndrome is a pre-infarction state seen in patients with critical LAD stenosis of the proximal left anterior descending artery or LAD. It was first described in the 1980s by Dr. Hein J.J. Wellens. These patients often have minimal or no chest pain at the time of presentation, but their ECG silently warns of massive anterior wall MI, usually within days if left untreated. So what are the clinical clues? History of recent chest pain, often resolved by the time the ECG is taken. No ongoing symptoms during ECG recording, minimal enzyme elevation or even normal troponin levels early on, and pain-free but ECG shows dangerous findings. Now the most important part, the ECG. There are two classic types of Wellens. Type A with biphasic T waves in V2 to V3 seen in approximately 25% of the cases, and type B with deeply inverted symmetrical T waves in V2 to V4, more common in 75% of the patients. Other ECG features are there is no significant ST elevation, no Q waves, and there is preserved R wave progression. Think of it like this. The heart is warning you quietly. There is no MI yet, but one is coming soon. The pathophysiology is simple but fascinating. Wellens syndrome reflects transient LAD occlusion followed by spontaneous reperfusion. This causes myocardial ischemia, especially in the anterior wall without infarction yet. The ischemia leads to repolarization abnormalities, giving us those characteristic biphasic or inverted T waves. But remember, this is only temporary. A full-blown infarction can occur within hours or days if not treated. Here's the critical point. Never send a Wellens patient for a stress test. Why? Because the increased demand during stress test can provoke complete LAD occlusion and trigger a massive MI. Wellens syndrome needs urgent intervention even if the patient looks stable. The key steps involves admit and monitor the patient, refer to a cardiologist as soon as possible, avoid exertion and stress testing. Early coronary angiography is the gold standard, and most patients will need a PCI with stenting or sometimes coronary artery bypass grafting. Medical therapy is usually supportive with dual antiplatelets, statins, beta blockers, nitrates, but it is not a substitute for intervention. If you found this video helpful, do like, share and subscribe. Drop a comment if you want more ECG based breakdowns. Until next time.